Thank you, May, for that kind introduction. And thank you also to the organizers of the 2021 Chong Hua Hospital Postgraduate Course, RED. Today, I'm going to talk about something that's going to be significant for a lot of us managing diabetes. The title of my talk is Glucose Monitoring from Prick to Scan, and I'm going to talk about continuous glucose monitoring. So this is my disclosure slide. And I'll start off by talking about the diagnosis and monitoring of diabetes. Now, for the longest time, we've been using fasting plasma glucose, OGTT, as well as RBS to diagnose our patients with diabetes. Now, A1C was not recommended to be used for diagnosis, primarily because we have not standardized our laboratories with NGSP. That being said, other countries in the world have been using A1C to diagnose diabetes. Now, the values here are all familiar to you. You all know this. And I think it's important that you understand that you don't just diagnose diabetic patients with one test. You have to do a follow-up, a repeat, and confirmatory test. When we monitor our patients, we use primarily BGM or CBG to check the blood sugars. Pre-meals, 80 to 130. 1 to 2 hours post-meals, you have less than 80 milligrams per DL. That has not changed at all for the past few years. Now, for us to understand the basics on A1C and blood glucose control, let's go back to 2009. In 2009, there was a study that was released by the ADA. It pretty much explained to us that during our waking hours, we actually spend half of our day in a postprandial state. The explanation for this is that every time you have a meal, your elevations in blood sugar, you have a postprandial state, which lasts about 4 hours. And added on to that is 4 to 6 hours of post-absorptive state. So since we have 3 main meals during the day and probably smaller meals in between, you can just imagine that your postprandial blood glucose levels will actually be a little bit elevated during the waking hours. And it's only on the evening that you actually have a true hypo or normal blood sugar levels. No? So in the morning, when you get the fasting blood glucose, that's the most important test that we actually get because that is reflective of the true basal levels of the blood sugar of the patient. Now let's talk about A1C. The A1C we use to monitor our patients, 6.5 to 7.5 indicates that you have a problem with the postprandial glucose. More than 7.5, meaning 2 components. You have a basal hyperglycemia, and of course, you now have the postprandial glucose derangements as well. Now, the deterioration in the blood sugar actually occurs with the duration of diabetes. So it's very important that the levels as well as the duration of diabetes is discussed with the patient. Now, in the first part of diabetes, what you actually see is really the loss of postprandial control. And this occurs at 4 years from the time that you started your diabetes. And your A1C will probably average between 6.5 to 6.9. Later on, as your diabetes progresses at 8.4 years and your A1C goes up to 7 to 7.9, you now have deterioration of your pre and post-breakfast blood sugars. At more than 10 years or an A1C more than 8, you now have a mix of derangements of pre-basal and post blood sugar levels. So this is very important that you understand these basic concepts of the A1C. Now, this is the typical way we monitor our patients. This is the SMBG, BGM, or CBG, as you may call it. Basically, you get fragments of time. You get samples for the blood sugar of the patient all throughout the day. So you get pre-breakfast, 1 hour post-meals, you have pre-meals and bedtime. So essentially, you're just getting a point in the whole wave or a picture in a movie. So you won't be able to see the fluctuations in the blood sugar, whether or not this goes up really high or very low. So essentially, you're just getting just a picture. So that is the problem. We're not able to actually understand what's going on with the patient. And perhaps that is an improvement that we would like to target. Let's talk about A1C. A1C is indeed the average of blood sugar for the past 3 months. Now, I'm going to show to you 3 different patients. The one on the right is 100%, very controlled, very good blood sugar within the range. The one on the left is a problematic patient, only 40% in range, 20% low, 40% high. And yet the A1C is still 7 for this patient. The one in the middle is pretty much in between both of them. The time in range is 70%, you have 25% high, 5% low. Now, what is time in range? Time in range is defined by the American Diabetes Association as the amount of time you spend in the target blood sugar range between 70 to 180. Now, this is a new parameter. We're learning to use this in the way that we're managing patients. Now, for you to get the time in range, you're going to need new devices. It's called continuous glucose monitoring devices. The CGM devices are already available. They have been available way back since 1999 when the first transdermal implantable glucose sensors were developed by Minimed, Medtronic, Dexcom. Improved this technology by producing wireless transmission as well as improvements in the monitoring of blood sugar through the reagents that they use. Eventually, in 2015, they were able to have mobile device compatibility, and the company called Sensionics actually extended the lifespan of these sensors to 90 to 180 days. It wasn't until recently that Abbott also got included with the set of developers when they developed 14 days no calibration flash glucose. So you will come across these companies when you talk about or review the data on CGM. So what is the data or what is the technology behind CGM? Essentially, it's electrochemical as well as optical. So you get the data of the glucose levels converted to analog or digital electrical signal. And this gets transmitted and received by a receiver or a reader. This receiver or reader will now be able to give you a graphical interface where it will explain to you really what's going on with the patient, including the trends, graphs, as well as the reports. No? So this reader is connected to a system. This system is now broadcasted to a networks that will make this data available for both the patient and the doctor. Now, this is technology in evolution. And as time passes, newer generations of CGMs are improving and accuracy is also improving for these patients. Ultimately, the goal is really to create a closed loop system. This is an artificial pancreatic device system. So the system includes a CGM sensor attached to the patient that communicates with your reader. The reader will now send this data to the computer that analyzes this data and sends a signal to your insulin pump, and the insulin pump will now release the insulin needed, exactly what the patient needs for the level of the blood sugar that is being detected. Now, this is amazing technology. It's already available, but not yet in the Philippines. So these are your common CGMs that are available worldwide. No? So in the Philippines, we have limited options here. We only have the Freestyle Libre 14-day system. But what is common among all the CGMs? You have a sensor, an applicator that goes with the sensor, also the transmitter and the software. Okay, you have a wireless system that connects the sensor and the reader. Some are still wired, but these newer generations are really very helpful. Some of these sensors can be used more than once, but often the systems only allow you to use it at a limited time. The sensors also need a warming up period, usually 1 to 2 hours before you can actually use the system. There is a lag time between finger prick as well as the sensor value. So you're going to have to look at that difference, and I'll explain it to you later. Data on food, insulin, and activities may be incorporated in the sensor readings. You can include this on the reader device, but all of these new generation CGMs are actually a lot better compared to the previous generation because there's less skin irritation as well as better accuracy with regard to their reports. These are all the systems that you can commonly encounter. You have the Freestyle Libre system 14-day, which is available here in the Philippines. You have the Freestyle Libre 2, which is available in the US and Europe. You have the Dexcom G6 or 6th generation CGM. You have the Medtronic Guardian CGM system and the Sensionic Eversense. So there are advantages and disadvantages for each of these systems. Essentially, what you need to know is that they work mostly in adults. There are some systems that will allow the use in younger population. There are alarms for highs and lows, visual alarms as well as audio alarms. And the data display will give you important data about what's going on with your patient. Okay. Now, the international consensus on time and range actually occurred in 2019. In that meeting, they actually talked about how significant A1C is in the current state and how the time in range will actually change the way we manage patients and whether or not this technology is actually helpful for patients. So some of the criticisms on A1C include lack of information and excursions. They don't know how the magnitude as well as the frequency of these fluctuations are. We don't know if these patients are having hypo and hyper because the A1C is the average blood sugar. Now, it can also be confounded by several conditions, which include anemia, pregnancy, hemoglobinopathies, iron deficiency. And therefore, some of these criticisms do identify that these problems you may encounter when you manage patients and you follow A1C only. Okay, so it essentially will not be able to reflect some of the major developments as far as your blood sugar fluctuations are concerned. But at the end of that conference, time in range was really the highlight. So they talked about time in range. This is a very important parameter that patients should be within the range that you want them to be. And that A1C in the end was a complementary parameter that will go hand in hand with your time in range. So what's time in range? Time in range is the period that you stay on that range that you want it to be. So I divided the group here in non-pregnant population on top and pregnant population below. So the time in range for type 1 and type 2 patients is more than 70%, or that's about more than 16 hours and 48 minutes. For those high-risk patients for hypoglycemia, the time in range is 50%, so about 12 hours. For the pregnant population, the time in range is more than 70% for type 1 patients. That's more than 16 hours and 48 minutes. For time in range in type 2, pre-gestational diabetes as well as gestational diabetes, they expect it to be higher. The values have not been released, but they want better blood sugar control for these patients. So this is a graphical interpretation or presentation for all of you to understand. The one on the left is non-pregnant with a time in range of 70 to 180. 70% is the target for type 1 and type 2. For higher risk patients, 50%. So you still have about less than 25% for hyperglycemia and hypoglycemia, less than 5%. And for those high risk, more than 50%, slightly elevated blood sugars with less than 10% hypoglycemia. And so these are things that you need to remember. No? So these numbers are very important. In the pregnant population, of course, you want better control, more control with the blood sugar of these patients, particularly for type 2 pre-gestational diabetes and those with gestational diabetes. Now, moving forward, the data tells us from many of the experts that a 70% time in range is equivalent to about 7 or 6.7 to 7. And that as you increase the time in range, what is important is your blood sugar also goes down and your A1C actually improves. So this will also be equating to better outcomes as far as our patients are concerned. So this is a standard report for ambulatory glucose profile. You see here percentage time, the CGM is active, your average glucose, which is 70 to 180, your glucose management indicator or estimated A1C at the time that you're examining this patient. Glucose variability should be less than 36% or at least equal to it. An average glucose profile, which is the day-to-day changes in the blood sugar, shown here on the bottom parts. So you have 14 days of blood sugar monitoring shown here. Now, let's explain what the difference is with BGM and CGM. So the BGM, or the capillary blood glucose, is really a reflection of the transport system of the body of the human being. It does not provide information about changes in glucose levels over time. So it's just a fraction of time that's being tested in your capillary blood glucose. The CGM, on the other hand, is more dynamic. So it is testing the interstitial fluid. It is continuous, so you get the current value plus the changes in glucose levels over time. So because of this dynamism, there's really the trend that you need to follow for these type of patients. Now, it's important for you to understand that you are looking at two compartments here. These are different compartments of the body of the human being. In physiologic conditions, they may be about the same, but there may be a lag when you follow the CGM over your BGM. Now, they are complementary. They will help you analyze as well as understand the blood sugar levels of your patient. And therefore, you should think of it that way. So this is the Freestyle Libre 14-day system with the Libre View. The system includes the sensor attached here to the arm of the patient. You have a reader here that you use to check the sensor, and the reader will give you the reports, episodes of hyperglycemia in quartiles. You will also notice and see hypoglycemia, as well as the charts and time in range. All of these reports will be seen on the screen of your reader. Now, this is Libre View, also a very important component. This is on a desktop that the patient or doctor can access. All of the reports are here, including the standardized report that we talked about earlier. So let's look at some of the studies on the Freestyle Libre system. Here, this is a study done looking at hypoglycemia. And essentially, they're looking at type 1 patients, more than 200 in 23 European states. They used the Freestyle Libre to follow these patients in the 6-month period. And they found out that it was very helpful in detecting hypoglycemia in these patients. No? So I think that they appreciated the fact that they can see the blood sugars more clearly as the trends are being shown here. At the end of the study, they did not see any difference in the A1C, despite the fact that they made some discoveries that the hypoglycemia was present among these patient studies. So these are for type 1 patients. For type 2 patients, you have the REPLACE trial, which again looked at more than 200 patients, 6 months prospective, open label non-mass study, 26 European states with diabetes centers. They looked at the A1C at the end of the study. And again, the Freestyle Libre 14-day system was found to be non-inferior to your BGM. And this is important data because this supported the notion that the Freestyle Libre could actually replace the BGM in monitoring non-critically ill patients. So both of these studies are very important. My insights into this is that impact as well as replace did give enough data to suggest that you can replace your BGM with your CGM 14-day system. Well, at least for in the outpatient setting as well as non-critically ill inpatients. Okay, so the key findings did show that hypoglycemia was easily detected by the system with the CGM system, and these also showed that there was an increase in the scan, so the patients were more aware of their blood sugar. But there's really no deterioration in A1C, primarily because the levels of blood sugar may have averaged out, so therefore there was no significant difference with the A1C. So this is a study that looked into the BGM, blood glucose monitoring, as well as the CGM. And pretty much it determined that there was indeed a lag time between the levels of your BGM as well as your CGM. In fact, 1 in 4, about 25%, did show that there was a difference of about 15 milligrams per DL or 15%. Now, 1 in 20 patients or 5% actually showed that it also exceeded 30 milligrams per DL or 30%. But at the end of the study, it pretty much told us that both systems showed more than 99.5% of the results were within the clinical accepted zone. So that means that you do expect that there's a lag between the two compartments, but in the end, it may appear to be not that significant because you are following the trends of the patient, and you will be able to see these trends as you look at the bigger picture, as well as looking at the fluctuations, as well as the levels of your blood sugar. Now, moving forward, this is a study that compared, again, your CGM versus the point of care or BGM or CBG. And this particular study showed to us that the Freestyle Libre CGM system was very useful, particularly in detecting hypoglycemia across the board, and in particular prolonged hypoglycemia as well as nocturnal hypoglycemia that wasn't really detected with your point of care or BGM. What about studies on COVID-19 as well as CGM? This is a study that was taken from Wuhan, China. Here, they compared healthy individuals versus non-diabetic patients with COVID-19. And obviously, you can see here, the diagram here, the graph tells you the fluctuations were more significant for those normal patients that had COVID-19. And they concluded in this study that indeed impaired glucose tolerance could be possible in patients that had COVID, despite the fact that in the beginning they were actually normal glycemic. Now, there are still some questions that are answered with your CGM, and indeed, the levels of blood sugar appear to be still need to be determined as far as your CGM is concerned, which is actually true for all previous studies that were established. At this point, glycemic goals will still have to be determined as far as our targets, but the current targets appear to hold true for a lot of the patients that have been studied. Now, let's look at this study. This is a case report from Japan. This is a critically ill patient that was admitted in the ICU with severe COVID-19. If you look at this particular presentation, you'll see here that there was IV alimentation, you had ventilation, you had ECMO, you had hemodialysis, and this patient was on insulin infusion. You'll notice here on the first 3 quarters, there's really fluctuations in the blood sugar of the patient. And on the last quarter, you will see a significant improvement as far as the blood sugars are concerned as you begin to taper off the insulin as well as the other medications that were given with this patient. Overall, the study did provide evidence that the CGM did have some utility in critically ill patients, in particular this COVID-19 patient. So let's look at some more of the data that's available. You have here the blue lines, the blue marker with CGM, the green marker with glucometer, and then the insulin requirements in gray. And you will notice that the graphs will tell you they're pretty much, they do fall on the same areas. So CGM was comparable to the result of the glucometer, but there were some interferences that affected the results of your CGM. This included signal loss, you had sensor compression with the movement of the patient, you also had hypothermia as well as hypoperfusion that affected the results. Surgery and of course your MRI would have affected or at least at some point removed the CGM during these procedures. What was important was that in this study, they combined the CGM as well as BGM, and this hybrid approach did tell us that with the presence of CGM, the number of bedside encounters was actually decreased also with the PPE use. You were able to maintain the glucose control, follow these patients up more closely. Documentation was easier, even with remote real-time glucose monitoring. These were very significant developments for the healthcare providers. And it did provide a comprehensive remote evaluation of the overall performance. They were able to see the bigger picture. Now, this is another study that looked into a comparison of your BGM or your regular finger prick, comparing 2 types of CGM, Dexcom G6 as well as Medtronic Guardian Connect. Both of these graphs will tell you they look similar, and therefore both of these CGM machines were non-inferior to your BGM. In fact, they were pretty close to the results that you had with your finger prick test. This is a study with one of our COVID patients here in Cebu. When we put the CGM in, he was already in the hospital admitted. We were trying to follow the blood sugars. In the first few days, you will notice here in the daily glucose profiles, on the lower part on the left side, you will see the blood sugar levels, daily blood sugar levels. You will notice that there are yellow areas indicating hyperglycemia. Not much of hypoglycemia for this patient, but at least for the 11 days that he had COVID and was being managed, of course, this patient had all of the medications, including steroids, as well as your anti-inflammatory medications. These were all given to the patient. Now, obviously, this patient did improve, and thankfully, he did recover from COVID. The last 3 days of the glucose profile will show you that the blood sugars did improve. And in fact, there were some points there that he already had some hypoglycemia. So we had to make some adjustments with the medications. Now, right in the middle, you see the ambulatory glucose profile. The spikes are particularly obvious after breakfast, after lunch, and a little bit over dinner, but they even out after bedtime. Now, you see here at the end of the 2-week study, the time in range of this patient was about 69%. So I think we were able to reach pretty close to what we would like it to be. So here are some insights with Freestyle Libre and COVID-19. There are no validated studies for the use of CGM with COVID-19, but the data is already coming. There are more studies being published about it. And this technology can be very useful in the management of COVID-19 patients. The current generation of CGM devices have proven that they are at par with finger prick tests. No? So the BGM and CGM appear to be very close in terms of their results already. As the newer generations of CGM come out, we can expect that the accuracy will still improve. The benefits are clear. The patients are very much welcoming this technology with no more prick, just a scan. Minimize healthcare exposure, real-time, and continuous glucose determination and integration with health systems. So definitely this technology will change the way the doctors and patients perceive and understand diabetes. So through the years, there have been many devices that were developed for monitoring blood sugar. You had a combo glucometer, which would test your blood sugar similar to your oxygen saturation. You had the glucotrack, which uses your earlobe to check the blood sugar level. So these are all interesting data from all over the world. Unfortunately, much of these technologies have been out on the market because of lack of accuracy, cost, or some sort of reaction with the reagents that they use. But what does the future hold for us? This is the past when they had the Gluco watch biographer that was very useful because it had 6 readings for 13 hours, 2 hours warm-up time. It needed calibration, but we were able to actually use it. The data was very significant and very cutting edge in 2001. This was approved by the European CE, the US FDA, but eventually was withdrawn from the market because of issues with accuracy and skin irritation. So fast forward to the future, we don't know what's going to happen next year, whether or not you'll be looking at your watch and not only looking at time, you may be also looking at the blood sugar. And we're hoping that will be a reality soon. So here are my final thoughts and perhaps some of my recommendations with regard to this technology. The current management of diabetes still lacks a lot of the refinements, and we would like this to improve. And the CGM will actually complement the existing diagnostic tests for following patients with diabetes. It's not likely to replace it. The technology is a game changer, both for the doctor as well as the patient, because it will help you understand and give you the confidence to, particularly for diabetic patients, no? In the setting of an inpatient, non-critical patient, and also the outpatient setting. The data we get from these devices will help us better understand how we should handle our patients. And we've now moved from the age of individualization to customization. The benefits are undeniable. However, this really needs to be balanced with caution about the limitations of the system. We need to use this technology for us to understand better how time in range will impact our patients. The cost may be prohibitive, and that's just a reality because this is new technology, but the convenience for those who can sustain it is really priceless. With that, I'll end my lecture for this afternoon. I hope that you will be able to learn something new. Thank you and good afternoon.